I think Lorraine, you might have moved the real Alicia Sigler into
She's
the
coming right. She's coming right back on.
Awesome. Cool. All right, great. Well, welcome everyone. I think we're going to go ahead and get started. Thank you for joining this webinar for the California Society of Plastic Surgery and the Baja Society of Plastic Surgery. It's really a pleasure to see this group come together. And we plan to talk today about really things that impact all of us. And really internationally, it's been very interesting to learn about a lot of the challenges that we face as a specialty, since we do not necessarily own any specific body part or demographic, and how, we really face a lot of similar challenges around the world with trying to protect our scope of practice and the quality of care that we're providing to our patients. So I think it would be really interesting to kind of share stories from across the border of what we've done in our respective communities. And I think there's been some really innovative and impressive initiatives on both sides. So I'm going to introduce our panelists. Just in order of who I see first. So first is Deb Johnson, who has been an incredible advocate for plastic surgery on a national, global, and certainly on a statewide scale, and past president of the American Society of Plastic Surgery. Would like to introduce Tim Madden, who's a lobbyist for the California Society of Plastic Surgeons and has been really just an incredible collaborator on a lot of the initiatives that this society has undergone to protect the ability of plastic surgeons in the state to provide the care that they have been trained to provide, and to combat some of the bogus boards and other threats to our scope of practice. And then it's my distinct pleasure to introduce Ricardo Vega, who is president of the Baja Society of Plastic Surgeons, and Vice President Alicia Sigler, and for them to share their experience with how they're facing very similar challenges with scope of practice, infringement of core specialists and non-core specialists and non-physicians even into the realm of what we provide and our scope of plastic surgery, and how we can maybe learn from one another and even collaborate to kind of elevate the safety in our unique cross-border region. So thank you all for joining us, and we're gonna go through just a couple of questions, and I'm gonna start with Deb. I'd love to hear from you, Deb. What do you feel is the biggest threat to scope of practice for plastic surgeons in California and in the US?
So I think, it's a little bit of a two-pronged sword. The first is encroachment of plastic surgery procedures by non-plastic surgeon providers. And those are in two camps. One is, we're all concerned about non-plastic surgeons performing aesthetic surgery, particularly on an outpatient basis, because it's so unregulated. And the California Society has been very diligent in trying to make outpatient surgery as safe as possible, mandating truth in advertising, malpractice insurance, accreditation. We've done a lot of things to try and nibble around the edges to try and make that safe. The second is other surgeons who want to do insurance-based what we consider plastic surgery procedures, particularly in the realm of breast surgery, because there are many breast surgeons, breast oncologists who are now wanting to perform the reconstructive procedures as well, doing implant-based reconstructions, and some of them are even training in microsurgical reconstruction. So that is a big risk to our specialty as well. And then thirdly, there's the risk of non-surgeons wanting to do things that we do. And we've had a huge influx of legislation and lobbying efforts from nurse practitioners, from optometrists, naturopaths, from physician's assistants, now trying to operate independently and move themselves into the realm of outpatient surgery, which, as we know, is less regulated, and they can get whatever a paying customer will pay them to do. So there's lots of things that we're fighting in different realms, different kinds of practitioners. And, Tim has been super instrumental in keeping an eye on the legislation and trying to help us be aware. Our legislative committee works very hard to try and look over all the bills and see what's going to impact us as plastic surgeons and what's going to impact our patients, and try to do the right thing to keep our patients safe. So in a nutshell, that's where we're at.
Wonderful. Thank you so much. And I just also want to let the attendees know that there is a question and answer function. So if you have any questions or want to contribute to the discussion, please feel free to type your question into that Q&A box. So Ricardo, we'd love to hear from you. Tell us what you think the biggest threat to the scope of practice is for plastic surgeons in Baja and in Mexico.
Thank you, Amanda. Hello, everyone. I think we can share on only the number one is the people who don't have the credentials to perform plastic surgery, and you can name them under the level of charlatans. Could be any other specialty involved, but plastic surgery, and they think they have the abilities to perform surgeries. General practitioners, even nurses, or aesthetics who have a few months course of such aesthetics procedure, no? And well, that's the number one. But this number one is linked to several situations and several branches that can make them easy to go on their under low practices, like offices or facilities who are not registered in the government under the name of any other practice, but they actually do plastic surgery or the so-called plastic surgery. We have also a very bad control in the publicity of these doctors or these persons. The social media and the internet and their websites, all of those sources, the patients are not well informed, and they cannot be enough strong to make a difference between the real plastic surgeons and who are not plastic surgeons. So I think there is a gray zone there that we need to work on. Clinics who are not properly regulated, the sub-register in the government in terms of the who is and who is not a specialist. Briefs in a different levels of government, that have to say that. They brief the authorities and give them under the table money for don't close the facilities or extend the way that they can still be out of the law. But recently we have some efforts that have been achieved. Very good news. Other problem that I think we have is when the authority came in front of the problem, a legal process, they are not qualified, or they don't know how to make a difference between a diploma of the real plastic surgeon or a diploma or who is not plastic surgeon. They have to be well informed, because if there are anybody around there who can actually read a real diploma or plastic surgery certification, they will go away, because they show a paper who say plastic surgery, or they show a license who have surgery, or the name cirugía en español, no? So there is a lot of things that are against our practice and against our intention to regulate the practice. The thing is that, sorry. I'm sorry.
So I think it sounds like there's a lot of common threats, certainly to scope of practice. It sounds like that specifically for the aesthetic practice that what I'm hearing from both of you is that there's the threats from people who aren't plastic surgeons and then, people who aren't surgeons at all. Deb, I think you brought up kind of maybe something that's a little bit unique. I don't know if this is something that has been an issue in Mexico where for reconstruction that there have been surgeons of other specialties like breast surgeons who have been taking on doing reconstruction. I think that's kind of a complex problem because in a lot of places it's hard to find plastic surgeons to do reconstruction because of poor reimbursement. I don't know if you have any thoughts on that. Deb?
We do, the oncologist have, this is lately that they try to do the breast reconstruction after the mastectomies alone without a plastic surgeon on a side. But in terms of years ago, there was the custom was to be in a team together, the plastic surgeon and the oncologist. It seems like not anymore. It's that common. They kind of mixed. Also, the gynecologists have been in their field, not only in the vaginal rejuvenation that they can allow to do, of course, but some of them do tummy tucks, lipo, breast augmentation, and general surgeon as well. And well, it's the same problem. I think it's a global problem because
Sure.
everybody wants a piece of this cake and they don't know how realize in their mind that they didn't bake the cake. They are not prepared to have a piece of this cake, no? And it's a way to say it, but we have a lot of interactions from other specialties in our field. This definitely happened.
Yeah, great. Well, let's talk about what possibly we've done to try to fight this, what worked and what hasn't worked. And I'm gonna start with Deb again. You want to talk a little bit about kind of the efforts that you've specifically been involved in to try to protect scope of practice for plastic surgeons, either part of California and this organization, and then also in your role as our national leader as president of ASPS.
Well, certainly, I mean, some of the younger surgeons, they don't remember that there were never cell phones. Some of the younger surgeons don't know that there were never outpatient plastic surgery centers. The first outpatient plastic surgery center in California was built by my senior associates, Dr. Fagella, Dr. Bruner, Dr. Osborne, former presidents of the California Society. They built the first outpatient surgery center in 1975. It wasn't until 1987 that outpatient surgery centers were first regulated, required to be licensed. So it was really the wild, wild west for a little bit. We actually got a bill passed through the legislature in 1989 that said you can't do in an outpatient facility what you don't have hospital privileges for. That was vetoed by the governor because there were many more of the charlatans, as Ricardo calls them, than there were of us. And so we've nibbled around the edges ever since then. And really, hats off to Jack Bruner, who was really the pioneer in all this and got me involved, because when I joined the practice, they said, we're in Sacramento, we're the ones who have to work with the legislators. It falls on us to try and be policemen of what's happening to plastic surgery. And so we were able to work and develop truth in advertising laws. You can't claim board certification unless it's a board, ABMS board. We were able to fight the cosmetic surgeons 4 times from becoming board considered equivalent to plastic surgeons. We were able to require accreditation for outpatient surgery facilities if they weren't licensed, and so all of this has worked to a degree to help patients, but there are people who, either are rogue and kind of work outside the system. They don't work in an accredited facility. There was recently a pediatrician who lost his license because he was providing liposuction in an unaccredited facility, had no surgical training other than a weekend course in liposuction. So it's very frustrating because we have tried to get people to follow the rules, but still enforcement is an issue. As I'm not sure how it happens in Baja, but sometimes it requires a really catastrophic incident to get things to happen. And so, people can fly under the radar and patients can be harmed, a little bit, but until somebody dies, basically, it's hard to get the medical board to take action. And so we continue to work on that. I act as a reviewer for the medical board, and see a lot of this sad underbelly of cosmetic surgery. So we keep trying to whittle around, but we face new challenges with the PAs recently got legislation through that allows them to do procedures without their physician supervisor in the room, which I think is quite dangerous. There, as Amanda, you may remember, there was a PA in San Diego who was doing outpatient liposuction and had hired an octogenarian ENT to be his supervisor, who was never there. Had bad outcomes. Finally, both of them lost their licenses. But now, that's going to happen again. So I'm very concerned. We're concerned with the nurse practitioners getting independent practice that even though we're trying to contain that, they may whittle around their edges and get themselves into situations where they can provide cosmetic procedures with no training. So one of the things that we are currently kind of brainstorming about is seeing if we can somehow legislate that outpatient surgical procedures can only be provided by people who've had ACGME surgical training. So at least that gets the weekend course people out. It gets the pediatricians out, but it doesn't protect us from the OB-GYNs and maybe even the dermatologists who have some surgical training. But we got to keep whittling at it.
Thank you. So Ricardo, you want to talk about your efforts?
It's like a mirror. We have basically the same problem.
Maybe you can tell us your briefly kind of the specific.
We have we have a law. It's activate is on the state law, under the state law in the last 5 years, that any facility or private clinic who have perform plastic surgery procedure need to be under the name and the license of a certified plastic surgeon. If you don't have that, they will close the clinic and they will proceed against the owner or the people who are in charge there. So we kind of cover that part of the private clinics or the outpatient facilities, but as well, if we don't have any catastrophic problem or any catastrophic disease with a patient or a disease or something happened there, the authorities will not be there by a regular basis. But we cover legally, we have that law that protect a little bit the specialty in that way. And the other terms that the people who do these procedures, they are under an illegal field, because it's very clear, especially in the state of Baja California, that you need to be plastic surgeon to perform to modify the contour or a body or the face. So if you are in an illegal practice and something happened, you will go to jail. We already have, the law has only 1 year active, and in jail is 2 two doctors who are aesthetics with general practitioners with this few months course for aesthetic surgery or whatever. They have facing 6 years of jail. And the
They
patient
were
did not die.
general practitioners,
Yes.
but
aesthetic.
physicians who were doing surgery with the.
That- You go with they call maestria en estética. And there's 2 years, once a month. Sometimes it's virtual, once a month for 2 years, and they have this little cedula or license. We are one of the biggest challenge for the Mexican plastic surgery because they confuse the authorities. They just not being understand by the Secretary of Education and the Secretary of Health. But now it's clear, no? Now we need to keep working and working and working and fighting this to maintain the level of clarity with the authorities that who is who, no? But we have been in a better place now. If you see back in the last 5 years, we are in a better place legally, but not in a better place in everyday basis. We still have a lot of problems with people who are under the law, who don't have the license to practice.
So I think it's pretty unique for Mexico to have it be a criminal offense to, do plastic surgery without being a board certified plastic surgeon. I don't know, Tim, maybe if you want to weigh in here, do you ever see that being a possibility in the US where that's actually a criminal offense to protect scope of practice?
I see Dr. Johnson starting to laugh a little bit, but I think it'd be really hard. I think the idea that Dr. Johnson outlined in terms of trying to get more your general practitioner, your pediatricians, and kind of keep them at bay is a great place to start. In California, the physician's license allows them to practice any type of medicine they want. The traditional backstop when it comes to surgical procedures, as you all understand, has been the hospital and the hospital credentialing process. And that's just not there in the outpatient basis. So I think a first step would be to try and change California law to say something along the lines of what Dr. Johnson was outlining in terms of who can perform surgical procedures on an outpatient basis. And then from there, maybe we can try and narrow it a little bit. It's my understanding, and Dr. Johnson may know, that Florida was probably a little closer to getting something like this in place. I don't think it was as specific as limiting it to just plastic surgeons. But I think it'd be really challenging to get something through, similar to what Dr. Vega was able to do in Baja.
It's a hard way. And we take photos and we make these files and files and files of malpractice, not only in Baja, all the country, through the Mexican Association. And for years, we have appointments in the Mexicali with the government and the Secretary of Health in Mexico City, et cetera, et cetera. But the path was dark, and then the light came over this path through the testimonials, documented cases from these people, and show them why is a public health problem. We go from there, like a public health problem, that if they don't do something to stop these practices. But we need to prove, like I said, files, testimonials of the patients, pre and post pictures, et cetera, et cetera, et cetera, et cetera. Several cases.
I would like to add to what Dr. Vega has mentioned about this case specifically of the two imprisoned physicians. The patient passed away. So that's why they are, facing this punishment, because there's already something really, really severe involved in the case. It's difficult to be putting in jail people who are just failing in, what they're supposed to be doing in terms of the scope of practice. And that's what Dr. Vega is saying, that we need more files and more testimonials and more, people complaining to the authorities that a non-plastic surgeon did the surgery and they're having a complication. But so far, this is something that at least we can prove that, okay, this happened in this clinic with 2 people who were not certified.
Okay, here's the data for 2023. 59 clinics and outpatient facilities were closed. From 59, those 59, 36 will never open again. 2023. The doctors who are in jail, for Alicia said, and 3 other doctors are in the process and the legal process for bad surgery and usurpers of the profession, no, charlatans. And the other 3 are in an upper trial for different specialty. These 3, one is an oncologist, the other one is a pediatrician, and the other one is pneumologist, who are in an open trial to practice plastic surgery procedures. So it's very interesting. I know the numbers are low, but at least some new guys were thinking and do some practice plastic surgery. They will probably think twice if in the newspapers and the media say, this guy are in trial, this guy are in jail, something can be changed in some way.
So to understand the process that results in imprisonment, is that required that there is some really devastating outcome like a death,
No.
or what? No, you could be in prison just for practicing and doing harm without
Exactly.
having appropriate credentials.
Hmm.
Interesting. Just for Deb and Tim, because it seems like some of kind of the loophole in California is that this ability to do things under your physician license without, necessarily having to work in an accredited center, which sounds like that's partially like something that they've tried to address in Mexico by having those centers be under the supervision of a board certified plastic surgeon. Do you see that as something that's changing? Because I think that that's something that can be also state dependent, right? And I think that was maybe part of the issue in Florida.
Yeah, in Florida, they did, the issue in Florida was where the core specialties came together. I think it was derm, ENT, and plastics, said that you can't, that med spas had to be under the auspices of one of the core specialists, that it couldn't be, a pediatrician or running a med spa, et cetera. So that was, that's a good step, but still, we in California, unfortunately, we haven't been able to require, particularly in local anesthetic patients. If somebody's doing local anesthesia only with, maybe some oral Valium or lorazepam or something, they don't have to be accredited. They don't have, they can do whatever a paying customer will pay them. And there are people who will provide, very low cost procedures, after doing a weekend course, and unsavvy patients just don't know. ASPS had a huge project called Do Your Homework, where they tried to educate consumers on, board certification and the importance of asking questions. They had a 10 checklist questions to ask your surgeon to make sure they're qualified. But unfortunately, there's a lot of patients that sort of, they think that getting plastic surgery is sort of like getting a haircut. And so they will go to the lowest cost provider, thinking that anybody who is a physician is qualified. And it is frustrating because a lot of these charlatans will prey on, non-English speakers, non-savvy consumers, people who are really looking for the cheapest alternative, and then they don't provide a good service for them, and patients can be harmed. One thing I think it's important for all of our listeners to know is that if there's anyone in your community that if you're seeing complications from another provider, that you're concerned about, you know, you can ask the patient to complain to the medical board, but you can also complain. It's an online, you can go to the medical board, and there's an online complaint form. It can come from anyone. You know, I recently had a case where a chief of plastic surgery at a hospital complained about a community surgeon because they were getting a lot of their complications admitted to hospital, and he felt that that practitioner wasn't, you know, appropriately trained. And so the medical board did investigate that, and you know, there was some justice that came to pass. So I think that if you know anyone in your, you know, we know, you know, in my own community, Terry Zimmerman was a dog on a bone with an OBGYN in town who was harming patients, and he eventually lost his license. So the wheels of justice grind slowly, unfortunately, in California, because the medical board is understaffed, and it takes a while for things to happen. And we haven't been able to criminalize things like Ricardo and Alicia have been able to. God bless them. So we need to work in that regard, but it is something that all of us can play a role in. If you see bad stuff happening in your community, you should report it.
That's a great point. And it's impressive what you're talking about, Ricardo, in terms of like how there was a large amount of data that was provided about all of these cases. How did you guys go about organizing that? You know, because that's something that's kind of unique through your society. Or
Yep.
where were those cases submitted that they were all organized to
The
demonstrate that this
cases
was
who
like a public
are,
health?
if a case have a bad result and a complication like some infections, or the patients are in and embolism or something, if the patient doesn't die, it's very hard to follow that case with that provider, right? But it's where the same as Deb said, we have to fill up the complaint and encourage the relatives, the family, to fill up the complaints together with us. And not in the same file, but we need it. Sometimes we drive them because they don't know Tijuana. Sometimes we drive them to the Ministerio de la Fiscalía, ¿no? The police officers, whatever you want to name it. And we drive them, and they fill up the complaint. And there are several cases who are in the same manner, that authorities of the government or the state realize what is really happening, but it's not under, because they send people to investigate. They don't do that. And to be realistic is on us. Most of the responsibility and most of the arms to fight this is on us, mouth to mouth. In the chat, we have a chat. This happened in that clinic, and this happened, and the name is this, the pictures and everything. Then we move, and then we have the bridges and the connection with the authorities to make this happen kind of really quicker than a regular citizen, right? Because we have the association and everything. But it's a lot of work to do, to finally see a path. Maybe we now want to live to enjoy that paradise without these Charlies, no? But we are on the path to get in and defend the specialty. The other bag we have is the unethical brokers. The unethical brokers are a terrible problem with us.
Can you explain that a little bit? Because I'm not sure everyone in California is familiar with the whole broker system.
This broker system is people who in some way connect in some part of your life with a plastic surgeon, and they think they can bring patients. That's how they start. Bring relatives and friends, etc. And the doctor or the plastic surgeon basically they don't do any marketing or any effort to bring patients, because these people bring patients to them, and they have a quote for the surgery, whatever procedure is, a percentage or a fee or something like that. And this broker is the owner of the patient. Sometimes they cannot do any follow-up on the patients because they are afraid that the plastic surgeon will steal patients from, from them. So there's the brokers are the cause of a lot of new plastic surgeons and non-plastic surgeons come over Tijuana and Baja in general, because there's a lot of patients who I don't know how they do it, but they are very good in that, very good in marketing, and they expose terrific cases who are, of course, not real, but they get patients, and not as they don't care about the pre-op evaluation. Sometimes the plastic surgeon doesn't evaluate the patient and make the surgical plan as we should do. They say, do this and do that and do that to that patient, and I pay you some. If you don't do it, I'll find another 3 or 4 in Mexico City or Guadalajara, and I bring them to do my services with my patients. That's the bad broker we are talking about, and there's a lot of people like that.
Is there any
Or
is there any
enemy in that case, or
regulation?
enemy also is our own colleague, certified plastic surgeons who do that and play that game with them. No?
Is there any regulation over the brokers or what they do, or that's pretty hard to manage?
Amanda, we're looking and have several hours of talking about this with lawyers and friends, and we haven't find not little a window that we can jump. In that case, it's very hard to figure out a legal model to fight these brokers. The only way is that we don't play their game, but it's very hard to say that. It's very hard to find that all the plastic surgeons who are young and need money, I don't know if you can tell that they are dishonest. Maybe not, but they are not playing the serious game of a plastic surgery. It's too many years of studying and too many years of school just to came muppet of these guys. No, it's very sad. I think it's very sad.
That's Deb, do you see any parallel that is like the brokers? That
Well, I mean, certainly, we can't, as plastic surgeons, we can't fee split. It's an ethical violation of our societies and of the board. So anybody who was found to be doing that would lose their board certification and lose their membership in the society. We do have, there are, kind of the corporate practice of plastic surgery now, where we have these venture capitalists that run clinics, and they have itinerant plastic surgeons coming in who don't see the patients before the day of surgery and often don't provide any of the postoperative care. And so that's a big issue. The American Society has been developing a kind of an itinerant surgery white paper to talk about the fact that if you're going to operate on somebody, you need to provide the good faith prior exam. You need to develop the planned surgical procedure. You need to provide the postoperative care. And if you don't, there are, certain patients that may travel. They may say, Amanda Gosman's a fantastic surgeon, I'm going to go to San Diego and have my surgery there. But when they go home, still Dr. Gosman is responsible for that patient and needs to assure that any other postoperative care that's necessary is arranged for in the patient's home community. So we're trying to develop the ethics around that. But it is, there have been cases before the Medical Board of California where some of these itinerant surgeons have gotten into trouble, had complications, didn't provide adequate follow-up, and have had license actions against them. So so we're working at it, but it is, you know, as we have the same issues here, Ricardo, as you. We don't have these brokers per se that own the patients, but we do have marketers who try to, you know, take money for sending patients our way, which you know, is a little bit dicey ethically.
And the brokers are paid for by the surgeon or by the patient or both?
Both. Both.
Interesting. There's a couple comments in the question and answer, Dr. Singer, and I think you touched on some of these issues, Deb, but just the multiple issues around operating in accredited facilities by getting around that by just doing local anesthetic, which I think you touched upon a little bit, which I know is really challenging, and there's certainly been some really devastating outcomes from local anesthetic toxicity and other
Yeah, I think that's become a larger issue of late. And we've also found that some of the cosmetic surgery courses teach people bad formulations for tumescent solution, dangerous formulations. I had a case recently where it was an epinephrine toxicity because they were instructed to put, 2 milligrams per liter in their bag, and they were putting in 5-6 liters of tumescent and getting hypertensive crisis and tachycardia, et cetera. So, it's a little bit of the blind leading the blind for some of these cosmetic courses. That's one of the things that Tim and I have talked about is seeing if we can legislate that any outpatient surgery, there'd have to be carve outs for, super minor procedures like taking a mole off or a laceration repair. But any surgical procedure, whether it involves sedation or general or straight local, that is serious surgery, needs to be regulated and needs to be an accredited facility. And if we could get it legislated that it has to be a surgeon, I think that would go a long way.
Excellent. And then the other comment that Dr. Singer brought up was just also about, the challenges, and maybe Tim, you can speak to this, about CMA and the, drive to try to get, some truth in advertising in terms of that you were board certified, but there wasn't really support from CMA in terms of indicating which board or ABMS board that actually was. So can say you're board certified, but it may be in pediatrics and be a situation like Deb was recommending.
Yeah, the California Medical Association has just historically been very protective of that physician license that allows them to do whatever procedures, whatever treatments that they want. I think that is waning over the last, let's say, decade. Dr. Zimmerman, who I know is on this, we had worked with CMA a few years ago about some of the ideas that Dr. Johnson was outlining, and they seemed open to it. I think they recognize that there are physicians with training in nothing related to surgery that should not be doing these procedures. And in terms of strategies, what Dr. Zimmerman and I talked about was, there are a lot of bad cases out there that the CMA doesn't want out in the public. And, in terms of strategies, I think what Dr. Vega outlined in terms of accumulating bad outcomes, bad cases, is really the way to shine light on this issue. So if we do end up going down that path, I think to the extent that we can share some of the examples that Dr. Johnson outlined in terms of the problems that are out there, I think it will help bring CMA along. It's hard to imagine that CMA would stand behind a pediatrician doing breast procedures under local anesthesia. So it's hard to imagine, but historically they've been somewhat protective of.
We were able, when the ABCS tried to get their most recent equivalency and were denied by the medical board, one of the things that we were able to show, which I think was quite effective, was that we went through all of their members and on the medical board website. And we found that it was something like 26% of them had license actions by the medical board against them for medical care issues, compared to only about 3% of plastic surgeons. So that carried a lot of credibility in the fact that they were not equivalent to plastic surgeons. So I think if we need to gather that information regarding physicians and mid-levels and non-physicians who are doing procedures outside of their scope and harming patients, and then bring that to the legislators to show them that we really need more regulation in the outpatient world.
Yeah, can you maybe explain a little bit about that last battle? I'm not sure all the people on the webinar are familiar with the ABCS and what that stands for, and kind of how that was that whole battle took place. As I think that was really something important for every plastic surgeon in the state. And
sure, one of the things that we had worked for early on was that for truth in advertising, you could only claim board certification if it was an ABMS board. And when the regulations were written, they softened it a little bit and said ABMS or equivalent board. And the medical board had the ability to determine equivalency. And one of the first boards to be deemed equivalent was facial plastic surgery, because they do have an ACGME fellowship in facial plastic surgery after their otolaryngology is completed. And so they were deemed equivalent. So an ENT who has done a facial plastics fellowship could say board certified in facial plastic surgery. But the American Board of Cosmetic Surgery also applied for equivalency. They were denied because they were not deemed equivalent in the level of training and education. They were allowed to reapply after 5 years. They did that. I think the third time they applied and were denied, they did over the years up their game. They did start requiring some testing and an oral examination, and it wasn't just that you paid your $250 and you got your board certification. But the third time when they were denied, they actually filed a lawsuit and got an injunction. The medical board was going to give up and say, okay, we'll just let you have it. But a lot of pressure from CSPS to get them to appeal that decision. And thank goodness they did, because they won on the appeal. And then finally in, what was it, Tim, 2018 or 17, they applied again, and they had again upped their game as much as they could. But we were able, we had kind of a little strike force of CSPS members that worked very hard to put together a really excellent PowerPoint presentation that Michael Long, our president at the time, presented to the medical board. We were able to show them that they did have many more license actions than we had, and that their education and training was not equivalent in scope and breadth, and they were again denied. And then finally, the medical board got out of that whole business of deeming equivalency, and so that's been put to rest. We did also sponsor legislation that said that if at a first patient encounter, you do have to declare your board certification to the patient. Say that whether or not you're board certified and what your board is, and you have to put that on your website. We got a lot of pushback on that, because people who aren't board certified don't want to have to divulge that they're not. So we keep pushing to try and educate the patients. But again, I think we've learned over the years that depending on the consumers to be savvy enough to know the difference is not good enough, because patients are still getting harmed. And so we really need to ask the legislature to step in and protect the patients from people who aren't well trained and don't exactly know what they're doing, can't handle complications, don't have hospital privileges to take care of their patients should something happen to them. And really, in the interest of patient safety, we need to make sure that surgery is done by surgeons.
Yeah, that is quite an incredible history, and I think feel like we're always kind of waiting to see what's going to come next. But it sounds like if the board is no longer kind of determining equivalency, that may be at least partly at rest for a while until the next iteration.
Somebody legislates it.
Yeah. This is like really fascinating, and like we're like coming close to the end of the hour, so I just wanted to kind of ask all the panelists kind of what, it's been educational to hear the different approaches that all of us have taken to protect scope of practice, from really organizing and collecting patient testimonials, taking those to the authorities and demonstrating a public health threat, and certainly to the level where it becomes a criminal offense in Mexico, which is really inspiring, I think, not just for us, but also I think for our global plastic surgery community that faces a lot of these things in different parts of the world. I think, having a responsive legislature is something that we definitely continue to strive for, and having, really advocacy initiatives such as through our local societies is one of the most critical functions of it. It's interesting also to know how your outpatient surgery centers are certified under your certification as opposed to just under a general medical license. That seems like another kind of protection. And then, for us in California, kind of trying a little bit of a softer approach as we're trying to educate the public, and then, trying to mandate this board's, or like American Board of Medical Specialties, which is that kind of overarching board for all of the different specialties, to try to make sure that we're excluding people who are really, I guess, the charlatans, but it doesn't exclude those people that are not surgeons, which certainly seems to be one of the larger threats. So looking forward, do you see, like, just love to hear from like each of you, what kind of potential ways that we can learn from one another or work together to kind of really try to protect our scope globally? Because I know, kind of talking to people from other countries that face very similar challenges, this is certainly not alone, even though we're in close proximity. So I don't know, Ricardo, if you want to kick it off and say anything that you think would be a
I think there's
next step.
two main branches. One is these two branches are the same for both of us, the two associations. The orientation and in the real and good information for our patients, well-informed patients. And the other one is let the patients know that they are responsible to choose the surgeon or the provider, and also they are responsible to file a claim if something came out and if they see something is not right. They need, some patients said, I didn't know I can complain. I didn't know I can go to the to the law because it's a doctor. Believe it or not, some patients say that. So we have the responsibility, it's our responsibility to find the ways that patients can be well informed, feel like they have empowered by the real surgeons to have and may be easier for them to fill up a complaint. And also, we can probably make a unique form to act between two countries on two states, two associations now, and together have some a website maybe together, a post or billboards, something that catch the attention of the patients. The Mexicans and the Americans, they know each other, they tag each other. They will be a shock for them. and see, okay, I feel more secure. And I have the phone number on the website of the Mexican board and the American Board of Plastic Surgeons. And I see the phone number of and the website or Instagram of the California Association of Plastic Surgeons and the social media of the Baja California College. That never happened before. I don't know if I'm right or no, or it's a romantic idea, but can be something different to show them that we are doctors first and then plastic surgeons, and we are worried about your security. Patient safety doesn't have borders. Patient safety doesn't have languages. Patient safety is worldwide. And we can probably send a message to all the world that we can work together trying to enroll a patient in a path with more safety, no? I don't know if you understand my,
Yeah, no, I think
I'm
that
so
that would
tired this
be-
time and my English is worse.
No, I think to summarize what you're saying, I think like having some type of repository where we're able to receive some of those complaints and on both sides would be very powerful. And then, you know, kind of co-branding that we are prioritizing safety and value board certified.
Safety and not money. I don't care if you go operate it here or there. I'm caring about your safe.
Yeah,
That's the message. It's very powerful, like you said, very powerful.
I love it.
And who can do it besides us? We have all the background
Yeah,
enough
absolutely.
to do that.
Deb, any thoughts from you as going forward? Is
No, I mean, Ricardo said it quite clearly. I think we need to work together and certainly through, you know, through ASPS and the Aesthetic Society now being international organizations. You know, we have all of our MOU countries that we're working with now, and you know, raising all boats for not only education and training, but also focusing on patient safety and the reliability of our members to provide good service and to work together. I think you know, if I have a patient who had a procedure in Mexico that comes to me with a complication, you know, I can call Ricardo and say, you know, this patient went to this place, and, you know, can you find out about this place and you know, make sure that they're on the up and up. I mean, I think that's a way that we can work together, you know, to make sure that we're working in the interest of patient safety, no matter where the patient lands, you know. So if someone, if one of my patients goes to Mexico and presents to a clinic there with a complication, you know, I'd certainly want to know about it. And you know, I think it helps us all to just communicate and try to do what's best for our patients. And certainly, you know, policing our own communities as best we can. By talking amongst ourselves in our state and regional societies and reporting to our respective government agencies when we see something bad going on, will go a long way, because, you know, if a complaint is filed, it has to be investigated. They don't sweep stuff under the rug. So don't think that you know, if you complain, nobody's, you know, it's just going to be ignored. It is investigated. So so if you see something, you know, say something, report it to the medical board, because it will be investigated.
Awesome. Alicia, any last comments?
Well, I think it'll be also a good idea in joining federations with other countries, because it's not only happening in Mexico, the medical tourism. Patients are going to Colombia, Brazil, other places like in Latin America. So there's a federation for all these Latin American countries for plastic surgery, but I'm pretty sure, you know, the United States would be able to join in an effort to have all, even Canada, to have all those countries from America, you know, to be all in contact, because those patients, it seems like we are all sharing them in a way, and we want like the best practice. you know, for all of them, for their safety. And I think all the countries are complaining about same thing. There's all those people that are non-plastic surgeons doing the procedures and having lots of complications.
Absolutely. Tim, any final comments?
Not much to add. I think they're all great ideas. If anything, I just wanted to thank you, Dr. Gosman, for pulling this together. It's been inspiring and motivating to hear the success that's occurred in Baja. So I think we can definitely borrow some of those ideas and hopefully learn from it and make some changes here that'll help patients.
Yes, well, it's really been a pleasure sharing stories with all of you, and I agree, it's really inspirational that each one of the panelists and everything you've done to protect the scope, and obviously it's an ongoing battle, but I know that it impacts many people well beyond our societies, but all of our patients too, and really love the idea of having open communication between the societies when we do see patients that maybe having complications, and whether it's a colleague that, you know, we would want to be able to discuss it with, as we all know complications happen, or if it's someone who had something done by a pediatrician, that would also be something that, you know, we could potentially continue to organize and try to report. So thank you for those great ideas, and thank you for everyone who attended, and we will kind of expand on this topic for sure at our advocacy day in Sacramento on the 13th. So I hope anyone who hasn't signed up will consider attending, and also at our national or our annual meeting in May, we'll continue this discussion further about international collaboration. So thank you all so much, and hope you have a wonderful evening, and big hand of applause for
you.
our great panelists. Thank you so much.
Thank you. Bye-bye.
Bye.